Yeah, so this locally advanced gastric cancer is more about perioperative therapy, and surgery definitely has a mainstay. So now we look at what are the surgical strategies, and we know that we'll look at the definition of locally advanced gastric cancer, what are the challenges, what is the extent of gastrectomy that is required, what is the lymphadenectomy status, what are the current guidelines, and what is the role of multivisceral resection. So if you look at definition, we'll come straight away. That is, locally advanced gastric cancer means T3, T4 lesions and N or N plus. If it is T3, then N0 is also locally advanced, or if it's T2, then N plus lesions will become locally advanced gastric cancer. So this is where the role will come. The challenges are in local advanced gastric cancer is because of the multi-organ involvement. So when there is multi-organ involvement, we are always worried about having a good R0 resection and thereby affecting the overall survival and disease-free survival. The morbidity of mortality of adding organ resection, additional organ resection is very high, and the mortality goes up to 13% if we add a pancreatectomy with gastrectomy versus gastrectomy alone. So that means while we are trying to get a R0 resection, we are actually putting this patient at a higher risk of mortality. So that is another challenge. There are higher risk of post-operative complications when we do extensive resection for this local advanced gastric cancer patients. Also the nutritional challenges, technical complexity, the learning curve required, extensive lymphadenectomy required, thereby the morbidity and the complications. And also when we do such an extensive resection, the post-operative functional problems is another important factor when we do about this surgery. So it doesn't end at R0 resection, but having a good quality of life for the patient is more important. So that is where the whole goals are different for early gastric cancer versus a local advanced gastric cancer. In early gastric cancer, currently the goal is curative intent with function preservation, whereas in locally advanced gastric cancer it becomes a curative intent with R0 resection, where the functional preservation takes a lesser priority. There are more lesser invasive methods coming in early gastric cancer, but you need more radical resections in a local advanced gastric cancer. More multivisceral resections, wherein in early gastric cancer we are moving towards wedge resections, sleeve resections, D1 or sometimes a D1 plus, but in locally advanced gastric cancers you need more extensive lymphadenectomies and more open surgeries than minimal access in the locally advanced gastric cancers. So this has been discussed already at multiple places. We should remember whether there is role in any other place, but in locally advanced gastric cancer, definitely diagnostic laparoscopy and parietal washings has a role. If we have to do this as part of staging, if the diagnostic laparoscopy and parietal washings is positive, it becomes a M1 disease and not a locally advanced gastric cancer. So this will change the whole scenario of the staging of the this particular patient and thereby the management. And what is the extent of gastrectomy? We have standard gastrectomy, which involves resection of 2/3 of the stomach with a D2 or a D1, D1 plus lymph node resections. But also we have a non-standard gastrectomy in local advanced gastric cancer. It could be a modified or it could be an extended surgery. So here the extent of gastric resection depends on the location of the tumor and the size of the tumor and also the lymph node status of these patients. So modified surgery is depending on the extent of the resection that we do, and also here a lymphadenectomy can be D1 or D1 plus. This is all in the scenario of a perioperative adjuvant therapy for a perioperative therapy for these patients. So upfront modified surgery will not be possible in a local advanced gastric cancer. So in extended surgery, it involves additional organ resection, or it also involves extended lymphadenectomy, maybe sometimes beyond D2. That is when extended resections will come. The extended resections will come into play even after a neoadjuvant therapy. So post neoadjuvant therapy, we have to redefine the local advanced gastric cancer, whether this patient would need a simple modified gastrectomy or he would need an extended gastrectomy. Like discussed in the proximal gastrectomy, we resect the esophagogastric junction, part of the esophagus, and the pylorus is preserved. And when there is more half of a distal half of the stomach can be preserved in proximal gastrectomy. So it doesn't mean that in a locally advanced gastric cancer, all of these patients would require a total gastrectomy. With the advent of the neoadjuvant therapy and the results, as I said, we have to review and restage these patients post the neoadjuvant therapy and see if you could still give them a organ preserving surgery for them. Of course, a subtotal gastrectomy and a distal gastrectomy are used interchangeably. Now we all have very much clarity on this one. These are usually done for lesions in distal body and antrum, though they may be T3 plus.